Let's start with this case of 52-year-old male patient with history of trauma for the ankle joint. I don't know, right or left, whatever. So let's start and see what do you think. It's an easy case, straightforward, nothing special. لينا اللي اسمع صوته يقوم وراها على الكيس اللي الزينه، تمام؟ حتى من هسه متفقين. يلا رشح لي نفسك انت بس احكي حتى.
هذا ام ار اي اوف انكل جوينت
T2 فات سات ساجيتال دائما ثلاثة T2 weighted image fat saturated sagittal showing
abnormal signal intensity at the posterior part of ankle.
Good.
At the region of insertion of Achilles tendon.
What do you mean by abnormal signal intensity? What's abnormal?
High signal intensity.
High signal. ما نقول abnormal. ما نقول high increased signal intensity, high signal intensity, whatever. Okay.
At the region of insertion of Achilles tendon.
Achilles tendon insertion. Okay.
Suggesting.
Then you have other sequences. شوف هو قبل لا suggesting. Maybe you change your mind. Maybe you confirm your. What do you think?
For me, this partial rupture of tendon.
Partial rupture of Achilles tendon. Why partial? Why not complete?
Because
هلا ده انتظرك أنا نأجلها على مودك. جيت والله جابك. Why partial?
Because still there is some continuity.
أول شيء to see the anatomy you use which sequence? Which sequence? T1. So go to T1 and see T1. Is the tendon which should be appear hypo or hyperintense? Hypointense. So is it seen here continuous?
No, it's the fluid.
It's fluid.
It's the fluid.
And where is the tendon? Can you see it? It's the tendon there. And this fluid, what signal intensity does it have on T1?
Low.
Is it low?
But
يعني خلينا نقول لو كانت urinary bladder
لا
راح يطلع هيج؟
لا.
لو darker لو brighter? Darker. So this has an increased T1 signal intensity. So what gives you high T1 signal intensity? Blood.
Yeah.
Okay? So there is a blood here indicating complete rupture of the Achilles tendon with hematoma. So first of all, where is the most common site of tendon rupture?
Site of insertion.
لا.
Just proximal to the.
No.
1 cm above the insertion.
Not 1 cm. There is an anatomical term for it. At the musculotendinous junction. It's the weakest part of the tendon. At the site where the muscle meets the tendon. There it's weakest, so it's commonly ruptured there. So you should see the tendon attached to the Achilles and muscle up, retracted. However, this is not the case. The tendon is ruptured from its insertion, probably related to the mechanism of the trauma. Okay?
No, it is in the tendinous parenchyma.
The tendon is completely ruptured from its insertion and is replaced by blood. The important thing here to mention is what? The surgeon needs what of you? Well, the surgeon needs for you to mention the distance of retraction, the gap. How much is the gap? You just, wait, don't leave the mouse. So you just measure the distance from here to here. How much is it retracted? So he can know how much traction he need to apply and technical surgical approach, exactly. And we can see it on the, let's see on the coronal image, you can see there is a big gap here from here to here. It's all from tendinous. And if you go to the axial image, you can see this is the muscle, okay? And suddenly it disappears, very beautifully demonstrated on the axial
This T2.
image. This is T2,
T2,
okay? And you can see the subcutaneous edema here and there, okay? So it's a very straightforward case of Achilles tendon rupture. Thank you very much. Hello. هلو وين تطلع جيت صدقك دخلتي برجليك زين this case is صراحة it's not hard but it has a very good teaching point and I wanted someone to do it today because يعني it has a lesson خلينا نقول بيها lesson 442 زين so 442 just a second so what I will tell you the story of this case which is by the way 25th of September it's a few days ago I will tell you the story of this case as it happens and you're sitting in your center or hospital or clinic and I'm the patient and you can do whatever you like. So what happened is that I was sitting in the clinic and an orthopedic surgeon called me. He said, I have a 22-year-old healthy, wealthy patient, male, presented with hip pain. So he went for somewhere else, did an MRI, and I am not satisfied with the report. So I will send it to you for re-reporting, for a second opinion, okay? I will not tell you what was the original report. He did not tell me, okay? What was the original report? I don't want you to be preoccupied. And you see and you tell me what do you think. The thing is,
History of the patient?
hip pain,
Just pain.
negative past medical history, negative past surgical history, no trauma, okay? The thing is, the radiologist who reported the case somewhere else is one of the people that I think they are very good radiologists. He or she was a resident here and they were really good and I respect their opinion. So I was very cautious, let's say, to say, no, that's wrong, because they are good, okay? So we have to do it again. So what was imaged is LSS and hip. The LSS was normal. So our problem is with the hip. See, and tell me what do you think, and tell me what do you need, and do the whole thing, okay? The LSS is normal, don't waste your time with it. Check it, no problem. And by the way, in the hip, they did a hip MRI with contrast.
Because we had an MRI قديم.
It's 2 days, 1 day before I saw it. Yani it's on the 25th of September. It's very new.
I mean, it's not in your center.
No, no.
The whole
I didn't repeat it, just re-reporting. Second opinion. And to help you, left-sided hip pain
Yeah.
and extra help.
Okay. This is coronal T2 fat sat.
Coronal T2 fat sat, okay.
Showing the both hip joint and the pelvis. I see normal both the sacroiliac joint.
Normal sacroiliac joint, excellent.
I see some abnormal high signal intensity in the muscles here.
Abnormal high signal intensity in the muscles where? Surrounding the superior pubic ramus, let's say, right? Or inferior?
The ischium.
Ischiopubic, okay. So there is a high signal intensity, edema بين قوسين.
Both the hip joints show normal disc space and normal.
Normal what?
Sorry, the joint.
Normal
Joint
joint
space.
space, okay. No problem.
And I think there is normal contour of the both femoral head.
Beautiful, excellent.
Okay. I see some high signal here. Maybe this fluid inside
It's a fluid inside the joint. This is the normal fluid.
Yes, if you see, it's normal, I think. But
Yep.
it's not present in the. Also present, yes.
Totally agree.
Yes, it's almost normal.
It's normal. I agree with you. So why he is in pain?
This is T2. Yes, T2
T2 without fat sat, coronal.
Yes.
It's not difficult.
The signals also is present. I don't know which this muscle is.
This is obturator externus muscle.
Obturator externus, okay. There is a high signal at the attachment with the bone.
Nice.
There's contrast.
Yes,
Contrast.
down. There is contrast. Go down, 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 down. Yes, and this is the contrast images.
This one?
No, no, the last one. بقبل الأخير.
Oh.
Eh.
I see there is high signal within the bones also.
So what does that mean?
The bone and the adjacent muscle. Also there is cortical bridge here.
Mm-hmm.
This is cortical bridge.
Okay. Cortical pathology.
Yes.
Where?
This is ischio, right?
Ischiopubic junction.
Yes, ischio.
Okay. With surrounding muscle enhancement.
Yes, both sides of the bone.
Beautiful. Both sides of the bone. What else? بعد one finding. Find it and we will start concluding, let's say.
Here on this.
Go up. No, no. Okay, go down, Hesse. Keep going. Keep. Okay. Now what? Go down a little bit. Opposite, opposite.
Also here.
Exactly. Also here. So, what's going on here?
The same as that. There is a high signal within the muscle and the bone.
Beautiful. It's almost the same pathology. There is.
So this is enhanced post-contrast?
This is post-contrast image. So, post-contrast enhancement in the bone and surrounding muscles. Excellent.
Acetabular, I think the part of acetabular.
It's basically the superior pubic ramus, or with the inferior pubic ramus or ischiopubic junction. صح؟ زين. Let's see it on. Let's see if there is any coronal image. No, I don't have any X-ray. Sorry. Do we have a coronal or something? Let's see here. This is without contrast, but let's see on coronal. So first of all, we have a pathology here.
It's expanding the bone.
Exactly. And we have something else here. See, this is the normal, this is the abnormal. Let's go on the coronal T2 fat sat. We have an abnormal increased signal intensity with surrounding increased T2 signal intensity of the surrounding muscles. Okay, and you can see here the cortex is interrupted. Okay, and if we go here, we can see also, compare with this side. This is a normal and this is the abnormal. Okay, so basically we have two lesions, one in the superior pubic ramus, one in the inferior pubic ramus.
Can we consider this line as fracture within the
So,
pathological fracture?
wait, so now you consider it a pathological fracture. Why pathological fracture? What do you mean by pathological
There is
fracture?
an aggressive lesion within the bone.
Aggressive lesion within the bone.
Causes
Like what?
extraction. Maybe secondary metastasis.
Metastasis. Nice. So, let me, till now you are walking the same steps that your colleague did. Exactly, to the letter. No, but I said in the beginning, he or she are one of the best. So you are going in a very good direction. يعني, okay. جل من لا يسوء. احنا مو wrong or right. احنا we are going on a logical pathway. So, let's try to draw something. So this is the اعطيني الماوس ما يخالف. It will be easier for me. So if we consider this the pubic bone. Okay, I'm not very good painter. So this is the superior pubic ramus, and this is the inferior pubic ramus, and we have something here, and we have something here. Tamam? So we have two lesions exactly opposite each other. One within the superior pubic ramus, one within the inferior pubic ramus. And we are thinking of a pathological fracture.
Because of the bone expansion, I said.
Bone expansion, bone, let's say, interruption, surrounding edema, surrounding enhancement, everything goes in the right direction. So now, why طبعا pathologic fracture we are saying metastasis صح؟ يعني the most common cause of a pathological fracture is metastasis. So why would the metastasis happen in only these two locations of the same bone, of the same side, and everything else is very normal?
I think we have etiology of stress fracture in this side.
First. Second, in the beginning, I told you there is no history of trauma. He has negative past medical history, negative past surgical history. Okay? So, why would we jump to a metastatic lesion? There must be something asshel, and he's 22 years old, he's very young. So, there must be something easier to explain that. So, what do you think?
Stress fracture.
Stress fracture is a possibility. If you look carefully, he is a very muscular guy. See the muscles, كلها عضلات. He is a very muscular guy. So, if we are thinking of stress fracture, what do you want to do to confirm it's stress or not? Or to think of something else? This is, I'm the technician, this is the patient, and you are the radiologist. I'm ready, he's ready, you're ready. What do you want to do? Sorry? Flare. The T2 fat cell, yeah, we have it.
Yes. It's like a step.
So we had, what would it do for you? What would
No,
it?
it be high signal in both.
So you don't want to ask the patient if he does any repetitive
Okay, about this.
exercise or whatever to confirm that he might have a stress fracture.
Yeah, okay.
ما تريدين تسألي؟
I said it's
We-
the athletic, maybe.
I told you he's a muscular guy. Okay? There is no history of trauma. Stress fracture is defined as what? Define stress fracture.
Normal pressure on the
Abnormal force,
repetitive trauma on the normal bone.
abnormal force on a normal bone.
Yes.
What's a pathological fracture?
It's abnormal.
Normal
stress.
force
Yes, only abnormal.
on abnormal bone. So we need normal force on abnormal bone, abnormal force on a normal bone to confirm our diagnosis. So I'm the patient. What do you want to ask me?
Yeah, exercise maybe.
Do you do an exercise?
Yes.
And he said, well, I've been enrolled as a military student last few weeks and I'm doing terrible hours of exercise from morning till evening. And this confirms our diagnosis of stress fracture. A big, huge difference between metastasis, death sentence, and stress fracture have 1 or 2 weeks of bed rest, and that's it.
Okay, so why there was a expansion of the bone?
It's inflamed. Repetitive trauma. He's fracturing and still training. شايفة بالمilitary بالجيش they have no mercy. يعني if you are dying you'll do the training no matter what. Okay? راح تركض لك 10 و15 و20 كيلو متر وتسوي push ups وتسوي مدري شنو وتريننج على الفايتنج. ده military بعد. Okay? And he's in pain. No mercy. Go do your exercise. Keep trauma, friction till it's all inflamed. Even possibility, maybe some mild form of osteomyelitis is a possible, but it is never a pathological fracture. اسبوعين 3 يستريح بالبيت تصير فيوجن انتهى الموضوع. I have no X-ray. Sorry. I didn't see an X-ray. it's not wrong to think of metastasis, but the history, the age, the findings, the distribution are not in favor of a metastatic lesion. So he told me I have to open him and to biopsy if it is metastasis to look for where, but he's completely healthy. كل عضلات وهذه وشغلات ما عنده شحم بس مصل باع. يا ريت لو اني مثله كان باع شوف المسلز من التريننج. شكرا اي. يعني انت تقول انت عجوز ما يخالف مشيها كيفه ضحك زين.
I couldn't imagine the location of the bones, the anatomy.
Exactly. That's one way to look at it. But anyway, the lesson from that is keep in mind, we are clinicians. We are not photographers. احنا مو بس نشوف صور. You have to see the patient, at least in certain cases. ممكن مو كل المرضى, بس in certain cases, see your patient, ask whatever you want to ask, get a good history, because it's literally difference between life and death. Okay? Thank you very much.
زين هذا ستريس فراكشر.
Stress fracture
إذا
طبعا.
ما صار زين after
معناها inflammation, صار osteomyelitis مكان الفراكشر. It's not metastasis.
osteomyelitis هم يصير زين.
ماشي اوكي. لا يصير نون يونيون ويصير ابسس ويصير فيستولا وكذا.
لا إذا مثلا يكون في تريتمنت بهذا الكونديشن تنطي انتي بايوتكس
اي
يعني ما يمشي يعني شو اسمه مرحله مع الابسس
اذا ما صار زين رغم كل هذا, then we might think of a pathological fracture. And if we think of pathological fracture, what would you do for him? خلينا نفترض انه هذا pathological وميتاستاسيس فرضا. What would you think? You have to search for primary. You have to do what? Chest, abdomen, pelvis, CT scan. If it is negative, PET CT scan. Exactly. Very nice. Good approach. مو عندنا فاينالست ثاني؟ منو الفاينالست؟ نياز لو شنقة؟ اثنيناتهم؟ ما اعتقد عندنا وقت تكفي. تعال عندي لك فد شيء يليق بك. عندي فد شيء يليق بك. خلاص. 4-4-1. اوقف. Wait. Leave the mouse. 4-4-1. So, this is a 58-year-old. طبعا كلها فريش هاي 25/9 لاحظ يعني كلها بعدها من الفرن طالعه هسه. This is a 58-year-old female patient. Her physician, gastroenterologist, told me she has jaundice. She has abnormal echo pattern on an ultrasound. I have absolutely no idea what's wrong with her. Okay? And there's no stones in the ultrasound. No stones, no whatever. Please do an abdomen MRI and MRCP and even give contrast if you need. And try to help me figure out what's wrong with this lady. Okay? So, okay. She came. We did an MRI. Of course, echo pattern of the liver in the ultrasound. But it does not look like liver cirrhosis. So do an MRI and let's see, can we figure it out what's wrong with her? He told me that there's no gallbladder stones. I didn't do the ultrasound. That's by phone. Huh? ادى what؟ يعني تعرف كل هالهاي بتلبتين فيفر نقولها كورسيكو باتن وام ار سي بي وهذه ماشي حاضر عندي تمام ولا يهمك. So tell me what's going on, or what do you think is going on? tell me what do you think? What are you thinking? فكر بصوت عالي. Think in a loud voice. شو تريد؟ measure? measure. Length. Yes. يعني do you need to measure to know this is the center gallbladder؟ يحتاج تقيسها يعني؟ واصلة للبلفس يا معود. So, first of all, what's the sequence? This is T2, fat sat, corona. Three things. T2, fat sat, corona. Of abdomen. Okay. Showing. Tell me the normal and the abnormal. Showing normal kidney. Okay. Distended gallbladder. What else? Well, possibly. Possibly, why not? We can, at least prominent portal vein. What else? Is this a cirrhotic liver?
Heterogeneous.
Okay. يعني cirrhotic ولا لا?
No typical features.
Not typically cirrhotic. It has
Nodularity.
no nodularity, no. Okay. Is it enlarged? Is there hepatomegaly?
Splenomegaly.
There is splenomegaly. Excellent. I was waiting for you to say that. There is splenomegaly, definitely. What about the liver?
There's dilatation of intrahepatic biliary duct.
Okay. Go to other sequences. لا أوف هذا الدكسن. هذا with contrast. Without, I think. Noisy image because she was uncooperative in holding breath. So, this is the MRCP. She said, what are these images? Tell me.
T2 star.
When you do this,
MRCP.
MRCP is the MIP image, maximum intensity projection image. These, they call it what? These are the source image. The source images. Okay? The machine do this. And after the patient leave, we do the MIP, which is this. Wait.
So this is called raw data?
Raw data, exactly. The source images. Raw data. This is the MIP. And these are the raw data. Okay? So we do this first, and then we reconstruct them into this. Okay? So let's go to the MIP and tell me, what do you see?
Intrahepatic biliary duct dilatation.
Okay, intrahepatic biliary duct dilatation.
With somewhat nodular.
شو nodular?
يعني nodular beaded in strict.
Beaded?
Beaded.
Okay.
Not so
Okay. Just leave them a little bit. Let me help you with something. We have this MIP rotational image. Sorry. Just rotate. Maybe it can help you in figuring out. So, now, what do you think?
There's no any pancreatic duct not seen.
Pancreatic duct is not seen, so it's not dilated, not affected, let's say. What else?
Common bile duct. Not continuation complete here.
Common bile duct, sorry?
There's no continuation of common bile duct.
يعني
There could be stricture.
يعني lacerated مثلا لو شو؟
Could be filling defect or
Filling defect or
stricture.
good or stricture or whatever. تمام. So, do you have any summarize the findings?
Findings.
شي على شي عندها المريضة شنو الفايندينجز؟
Findings. There's over distended gallbladder.
Distended gallbladder, splenomegaly.
Intrahepatic biliary duct dilatation.
Keep it quiet. Sorry, intrahepatic biliary duct tree dilatation. What else? Do you have any idea what's going on with this patient? What's the diagnosis or differential?
Differential.
Whatever يعني ايش راح تقول لهذا physician? What would you say to the physician?
Extrahepatic biliary duct dilatation. Those dilatation.
And by the way, this is very typical. Typical.
Could it be Merisi?
Merisi syndrome. What's Merisi syndrome? Let's going one by one. What's
Bile duct
Merisi?
dilatation. Bile duct obstruction
Okay.
by the stone.
By a stone.
Cystic.
Stone is cystic duct. Compressive on the bile duct. Causing biliary tree dilatation.
Intrahepatic biliary
Do we have a
dilatation.
stone?
We don't see any stone.
We don't see any stone. Good. So it's not Merisi. What else?
Classical tumor, but no, why didn't cause dilatation to gallbladder?
نفس الحاجة لو بالنسبة لي.
Tumor
Tumor.
could be classical tumor,
Cloud skin tumor. Cloud skin tumor.
but
Would
not
it-
cause gallbladder
Okay.
dilatation.
Wait. So let's discuss it from the beginnings because it's 9 o'clock and we don't.
But
Dr.
it's
Falah,
splenomegaly,
oh, I see.
but splenomegaly,
First of all, we have splenomegaly.
yes,
We have kind of
liver
hepatomegaly.
We have
liver
variceal
hypertension,
vessels.
Wait, let's approach it step by step. We have splenomegaly, we have hepatomegaly, we have prominent portal vein. We don't have signs of cirrhosis. No ascites, no nodularity, no masses. In the MRCP, which is the key in this case, we have dilated intrahepatic biliary tree with multiple innumerable short segmental narrowings everywhere. Just rotate the image, you can see narrowing here, narrowing here, narrowing here, narrowing here, narrowing here, narrowing here. Everywhere there are multiple focal segmental narrowings. And even in the CBD, there is a narrowing here, and a narrowing here, and a narrowing here. Everywhere the biliary tree has multifocal narrowing, 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 narrowing. Confirming this is a case of sclerosing cholangitis.
but not typical feature.
It's very typical.
Not really.
Look it up. طلعها بالجوجل بالورقة. It's a typical case of sclerosing cholangitis. And by the way, can anyone tells me what is the usual age of presentation of sclerosing cholangitis?
14,
It's usually more than 50 years old. Usually more than 50 years old. Okay? So this is
Longest time.
yeah, the presentation is after 50 years old, and this was a case of sclerosing cholangitis. The patient was scheduled for cholecystectomy, which was of no benefit. يعني cholecystectomy ليش؟ ما بس شافوا extended gallbladder خلاص cholecystectomy. لازم كاي على التريتمنت for sclerosing cholangitis. Microcirrhotic process. The liver is abnormal architecture, causing dilated portal vein, causing splenomegaly, the whole thing. Kind of. Exactly. Okay? Very.
هذا بيدد يعني
هاي كلها هاي نشوف هسه هاي الدكت شوف هنا discontinuous هاي discontinuous هاي هنا نارود هاي نارود اوقف خلي let's make it a little اعطيني الماوس let's make it a little bit more obvious هذا كله تشوف شلون باوع you cannot find any biliary duct that is continuous. It's all interrupted everywhere. Even the CBD is narrowed here and narrowed here. Okay? Everywhere is multifocal, narrowing. Okay? So, thank you very much. See you next week, inshallah.